Good morning, good evening to all. Welcome to the 22nd ACNN Webinar. And I will be the host for today. And today our speakers will be Professor Youtu Wu. He's a neurosurgeon attached to the neurosurgery department, Beijing Shenhua Hospital. He's going to talk on surgical management for pituitary tumor. And our second speakers will be Miss Peng Wei LU. She's a charge nurse of neurosurgical oncology ward attached to Beijing Tiantan Hospital. And she's going to talk on nursing management post-transsphenoidal surgery. Our second chair will be Prof. Li Zhenyi. He's a neurosurgical department attached to Beijing Tiantan Hospital and is a good friend of Prof. Youtu Wu. And our second chair will be Miss Lu Miao. She's a chief nurse attached to the neurosurgical ward Beijing Shenhua Hospital. Our commentators for today will be Professor Dr. Gopal Sedan. He's a professor and head of Department Neurosurgery, Institute of Medicine, Kathmandu, Nepal. And our second commentator will be Dr. Selvi Oswari. She's the skull-based and neuro-oncology surgeon, pituitary team, Indonesia National Brain Center Hospital, and also the founding director, Indonesia Pituitary Community Foundation. So without further delay, may I call upon Prof. Gato to give us a few words?
So, hello, everyone. So I think that today we focus on the pituitary surgery or treatment, I think. Maybe in Beijing, you may have a lot of cases of transsphenoidal surgery and also many patients, I think. So we are very much looking forward to both lectures. Thank you.
Thank you, Prof. May I invite our first session chair, Prof. Li Zhenyi, to chair the session for Professor Youtu Wu. Prof. Li, please.
Thank you. Thank you. Good evening, everyone. I'm in America, so it's morning, 6 a.m.
Okay.
But I must say good evening, everyone. Welcome to the first session. The first speaker is Youtu Wu. He's from Chang'an Hospital, Tsinghua University, China. Professor Wu has been dedicated to endoscopic surgery, and he's a skilled neurosurgeon. Today, his presentation is titled Surgical Resection for Pituitary Adenoma. Thank you. Professor Wu.
Hi, everyone. Good morning, good evening, everyone.
Good. Thank you, Prof.
Okay. Thank you for the invitation of conference group and the introduction of host. I'm Dr. Wu Youtu from Beijing Tsinghua Chang'an Hospital. Today, I will share the topic of a case of pituitary macroadenoma, neuroendoscopic transnasal pituitary tumor resection. I will introduce the topic from the following parts. First, we will review the basic situation of the patient. The patient is the female, 64 years old, and the patient was admitted to the hospital due to dizziness, headache, and blurred vision for 2 weeks. She found lesions in the cellar area in other hospital. Later, he came to our hospital for surgical treatment. The patient was usually in good health with no other chronic disease, and the entire family, 64 years old, the patient was admitted to the hospital due to dizziness, headache, and blurred vision for 2 weeks. She found lesions in the cellar area in other hospital. Later, he came to our hospital for surgical treatment. So after admission to the hospital, we perform physical examination, and the examination show the patient's consciousness was clear and visual field was normal. There was no manifestation of acromegaly. So we can see the hormone test show the IGF-1 was significantly increased, was 3 times higher than the upper limit of normal value. So this is patient's MRI scan. We can see the lesion in the cellar area, a huge overall soft tissue signal in the cellar, showing echo signal on T1 and a mixed slightly higher signal on T2. Enhanced scan suggests the lesion show the uneven enhancement, and the pituitary stalk is not clearly displayed. The optic chiasm is compressed and uplifted. Combined with the patient's physical examination sign, MRI scan, and laboratory test, we think it's a GH secreting pituitary microadenoma. The treatment plan was transnasal pituitary adenoma resection. So let's see our video. The first step to expose the sphenoid sinus opening. So we can see the sphenoid side sinus opening. And the second step, we will make a mucosal flap. So this flap is very important for the reconstruction of school base. So it's very important step. So here is the paddled mucosal flap. Yeah, it's a mucosal flap. So the third step is to expose the cellar floor. We're removing the nasal septum and expose the anterior wall of sphenoid sinus. So this is the sphenoid, the anterior wall of sphenoid sinus. So we have to remove this part. Yeah, during the process of exposing the cellar floor, all septation should be removed. After remove all septation, we use a calcium clamp to remove the cellar floor. So fully exposure of cell floor is very important because the tumor is the growth hormone secreting pituitary adenoma. So completely tumor resection must be achieved. So we can, we can see the extent of cell floor exposure superiorly up to the optic canal and laterally to the internal carotid artery canal and OCR. The fourth step, we began tumor resection. We have to resect the tumor carefully, and so we can see the internal carotid artery and the median wall of cavernous sinus, and these walls also be removed. During this process, it's very important to protect the ICA, the internal carotid artery. Yeah, the superior resection must reach the diaphragma. In this patient, diaphragma has been thinned by the tumor compression. So the entire diaphragma is deficient after the tumor is removed. So through this defect, we can see the optic chiasm and the anterior cerebral artery. The tumor has been completely resected. So finally, we perform school-based reconstruction. First, we use artificial dural to seal the cellar. Then we cover the cellar floor with the particled mucosal flap. And we pack the cellar floor with iodoform gauze and support the nasal cavity. Surgery is not completely finished. Let's review some key points during the procedure. First, we need to identify the opening of sphenoid sinus. So this is opening of sphenoid sinus. And we need to make a pedicled mucosal flap. So this flap is very important for the reconstruction of school base. In the third image, we can see the anterior wall of sphenoid sinus. We have to remove this part. So this image shows the full exposure range of cellar floor. The fifth, this picture we can see the internal carotid artery. So we have to protect this artery. It's very important. So this picture shows the diaphragm become very, very thin. After the tumor is removed, we can see the optic chiasm, and anterior cerebral artery. The last one is reconstruction of the cellular floor with mucosal flap. So there are some key points of the operation. The first one is the full exposure is very important to resect the tumor completely. The second, a petticoat mask mucosal flap is needed. The third is a sharp resection of tumor around ICE to avoid excessive retraction of artery. The last one is cellular floor reconstruction should be reliable. Postoperative medication is maintain the balance of intake and output, correct electrolyte disorders, and prevent infection. This is the post-operative MRI scan. We can see the tumor resection is very satisfactory. The hormone test suggests growth hormone is controlled below 1 nanogram per milliliter, and IGF-1 returned to the normal level. The patient achieved the biological cure. There are no operation-related complications, no infections, no cerebral spinal fluid leakage. So it's very good. So finally, to summarize, growth hormone secreting pituitary adenoma must be fully resected. Many scholars also recommend that median wall of cavernous sinus must be resected to achieve biological cure. To achieve complete resection, the tumor should be fully exposed. During operation, attention should be paid to protect the internal carotid artery and the important nerve structure in cellular area. The last one, reconstruction of skull base is very important to the success of operation. Oh, thank you.
Thank you for your outstanding presentation and video. Thank you. No, for acromegaly, the circular resection may be the first choice. And Professor Wu gave us outstanding video. Learn me how to resect a tumor better. Thank you. Next, I would like to invite Professor Siden and Dr. Osbury to share their comments. Thank you.
Thank you. Thank you. Thank you, Dr. Lijen. It was an excellent step-by-step presentation. Step by step, it was like picture perfect the way he explained all the steps of the surgery. And pituitary tumors, if you do a good exposure and do a step by step, even for a functional tumors, because these acromegalies and Cushing's disease, they are the functional tumors. In the functional tumors, our aim is to remove as much tumor as possible, so that even if a small bit of tumor is left behind, that can secrete the hormone and still continue with the symptoms. So it's very essential to do a very good exposure and remove as much tumor as possible. So my question is whether you use a navigation routinely or do it without using a navigation for the approach.
Thank you for your question. Okay, yeah, exposure is very important. We use the navigation. Sometimes we use navigation. It depends. It depends the tumor size. I think this patient had a regular tumor size, so we didn't use the navigation. But for the big, huge tumor size, tumor, we will use the navigation to protect the ICA and some nerve structure. Yep.
No, one more thing, because this symposium is for the nurses as well. So how much do you involve the nurses during the surgical treatment process? The OR nurses, the nurses in the operating room.
So pardon, sorry.
Because while we operate, we generally talk more to the to the medical team, like the residents or the junior faculties. So how much do you involve the nursing staff during the surgery? That was my question. So,
Professor Wu, Professor Sidan ask you，这个手术是你一个人是从头到尾做完，还是前面有一些住院医师啊，还有别人帮你来做完？
Oh yeah, okay, got it. Yeah, I performed the operation by myself. No, and my resident, I have a resident. Yep.
thank you.
Next, I would like to invite Osbury, Dr. Osbury, to share her comments.
Okay, thank you very much. First of all, congratulations for the very thorough presentation. I really like how you give the step-by-step. I think that will help everyone to understand, including that I understand that in this webinar, we have also our nurses here, which I think it's very important for them to also understand the step-by-step during operation. And I think the teamwork is paramount, and it's something that needs to be, I understand that you are doing the surgery with the residents, but I think it's also very important to have the nurses on board to know where we are exactly at the steps in the operation. So thank you for sharing a very detailed and thorough description of the surgery. My first question would be, would you mind sharing your preparation before the surgery? For example, do you do like, I don't know, like the sinus endoscope bedside, or how can our nurses help to prepare before the surgery, and then after the surgery, what kind of collaboration you have with your nurses there, to have better outcome for the patients?
Yeah, it's a very good question. Yeah, we will before the operation, we will cooperate with our nurse to give some nasal care. So we use some medicine to the patient's nasal, so it can help. We perform the operation smoothly.
And how about after the operation? Because as we know, there are several possible complications that might happen with this procedure, like the eye or, all the leak. So how would you prepare there in collaboration with your nurses there?
Yep, I think it's after operation, we will invest the patient's situation very carefully. So the nurse is very important to care to investigate the nasal leak, the CSF leak. So it's very important, and the temperature is very important.
So when do you start the nasal wash? After the surgery, right after, or you wait until 1 or 2 weeks after to make sure whether
yeah.
you have no leaks?
Yeah, 3 weeks after the surgery. Okay, thank you. 3 weeks. 3 weeks.
Really?
Free.
Yep. 3 weeks. Yep.
Okay, I think it's also very important to, to have everyone in the team to understand that the nasal wash is very important. But then I think in the beginning, I also usually start 2 weeks after the surgery, just because I don't want to get confused whether it's a CSF leak or it's from the nasal wash. Is it also the same with your opinion there? Yes. And for the nasal flap, do you do for every surgery or only selective surgery?
Not every
The
surgery.
flap, every
Yep.
surgery.
Not every surgery. Not every surgery. It's just for the maybe the patient have a huge a big tumor size and the opportunity CSF is the risk is very high for the patient. We will make a pedicled mucosal flap.
And maybe one last question.
Okay.
Is there anything different in terms of the preparation, also intraoperative or the postoperative care for the growth hormone secreting pituitary adenomas with the non-functioning one? Is there any difference in your protocol? For example, in my practice, for if it's a growth hormone secreting pituitary adenomas, and we already detect in the beginning, so we are before the surgery, because there are so many possible cardiac complication because of the growth hormone itself can cause more cardiac complication in the patient. So we usually have the patient underwent a 24 hours Holter monitoring. So not only for 10 minutes EEG, just to find out if there's any changing in the rhythm of the cardiac. That's what we do differently for specifically for growth hormone. But is there any other difference in your practice if the patient is a non-functioning with the functioning growth hormone patient in your protocol?
So did you mean do I have a difference plan for the NFPA or functional pituitary adenoma?
Yes, the non-functioning and then functioning. Do you have any difference in protocol?
Yeah. We have some difference. Yeah. For the non-functional non-functional pituitary adenoma, we will recommend the surgery firstly, and for the functional pituitary adenoma, sometimes we will recommend the medication, so medicine therapy. Yeah, it's a little different.
And for the growth hormone, 1 day after the surgery, will you check for the hormonal function day 1, or how is your protocol? Is it maybe 1 month, 2 months after the surgery, or day 1 you already check the hormonal level for this growth hormone secreting?
Yeah, we will check the hormone level after surgery. 3 days. The first
3 days.
First one is 3 days. Yeah, and every month for 6 months.
Okay. And maybe last question. So as we know that the recurrency rate is pretty high for the growth hormone secreting pituitary adenomas. How is your experience in that matter? If it recur again, how would you proceed if the tumor come back for the growth hormone?
Yeah, it's very difficult. For the patient, the situation is very good. We will reoperation, give another operation if the tumor is very difficult to reset because of it's very near to the ICA. The cavity, the artery. We will recommend gamma. Gamma and the gamma therapy. Yeah, gamma therapy.
So you do gamma knife if
No.
there's recurrence?
Yeah. Just
Okay. Okay. Thank you, Professor.
Oh, thank you. Good question.
Thank you for the excellent presentation and comments. Because Professor Wu is a skilled neurosurgeon, so he said if the tumor come back, he will firstly resect the tumor. But in my opinion, I think the patient can receive stereotactic radiosurgery, and it may be safe. No, I would like to say the first session should be ended. No, the next session, can we begin?
There is one more question. Catch up, please.
Yeah, thank you so much, Prof. Yeah. Thank you, Professor Youtu, for this presentation. My name is Ikechukwu Aniako. I'm a Nigerian neurosurgeon. Are you hearing me? Okay. So please, in your procedure, do you do a purely endoscopic procedure, or do you augment? Is it augmentation along the line with microscopy? Do you do it purely endoscopic, or is there any augmentation with microscopy? The microscope. Did you hear me? Yeah. Do you do?
Yeah, I can hear you, but not so clearly.
Yes, purely endoscopic, or is there any augmentation with a microscope?
Oh, microscope. Yeah. I do some microscope.
Sorry.
Yes. I do some micro surgery. So.
Okay. Yeah, thank you so much. I so much appreciate Dr. Oswari has really dwelt on so many of my questions, and it's been interesting listening to you. A wonderful presentation. I appreciate. Well done.
Oh, thank you very much.
Okay, thank you, Prof. Youtu Wu. If there's no further question, shall I call upon the second chair, Ms. Liu Miao, to chair the second session?
Okay, thank you. Okay.
Yeah, okay.
Good
Continue.
evening, everyone. I'm Miao from Beijing Tsinghua Chang'an Hospital. It's my honor to serve as the chair for the second session. Now it's my pleasure to introduce our next speaker. We have Ms. Peng Wei LU from Beijing Tiantan Hospital, a top neurosurgery center in China. She is the head nurse of the neurosurgical oncology ward. She has published 4 SAI papers and lead 5 research projects. Tonight, she will talk about nursing management, post-transsphenoidal surgery. Please welcome Ms. Peng Wei LU. Thank you.
Now, can you hear me?
Yeah, now can, yes.
Yes.
Okay. Okay, I will start again. You
Yeah,
can hear me?
please. Yeah, please.
Yeah. Okay, dear professors, thank you for giving me this chance to present my work. I'm from Beijing Tiantan Hospital, Capital Medical University, Department of Neurosurgery, Peng Wei LU. Today, I will share the topic nursing management post-transsphenoidal surgery. I will mainly introduce from the following aspects. First, I will give a general overview of the treatment for solid tumors. Then, I will talk about perioperative management. After that, I will cover post-discharge care. Finally, I will wrap things up with a summary. First, let's talk about solid tumors. They are quite common in neurosurgery, accounting for 10% to 20% of all in cranial tumors. The main types include pituitary adenomas, craniopharyngiomas, tuberculosis tumors, as well as germinomas in the cellular and supracellular regions. Although most tumors in this area are benign, they are located deep inside the brain and very close to many critical structures. Because of this, complete surgical resection can be difficult, leading to a relatively high recurrence rate. What's more, patients often face post-operative complications such as neurological deficits and endocrine or metabolic disorders. Common symptoms of solid region tumors include several aspects. First, symptoms of increase in cranial pressure, such as headache and vomiting. Second, symptoms caused by pituitary hypothalamic damage. For example, when the tumor compresses the anterior pituitary gland, it can lead to insufficient secretion of growth hormone, which presents as growth and developmental disorders. Patients can have symptoms related to hypothalamic damage, which one include low body temperature, somnolence, and diabetes insipidus. Last but not least, patients often have symptoms related to visual acuity and visual field impairment. Lesions in the solid region mainly revolve the hypothalamus, pituitary stalk, and pituitary gland. They may also extend to the optic pathway and the circle of valence. All of this makes surgery very challenging for neurosurgeons. Fortunately, with advance in neurosurgical techniques, in particular the development of new endoscopic techniques, we have gradually achieved higher rates of gross total resection and better outcomes for these lesions. Let's take 2024 as an example. That year, we did a total of 1,587 surgeries. Among them, nearly 1,500 were grade 5 surgeries, which accounts for more than 94% of all the surgeries we performed. And our three major advantages disease types are craniopharyngioma, pituitary adenoma, and choroidoma. Since we often perform a new endoscopic transnasal surgery, we have also gained some experience in how to take good care of patients who undergo this type of surgery. So let's move on to our main topic, perioperative management. First, let's talk about perioperative management. It's the most basic and fundamental step in treating patients with solid region tumors. Specifically, the Pre-operative nursing work mainly includes these aspects: admission screening, health assessment, health education, routine preparation, safety nursing, and psychological care. All these parts are closely connected and play an important role in ensuring the smooth progress of the operation. Let me break down the pre-operative admission screen. First, we will take a detailed medical history from the patient, things like their main symptoms, the current condition of their illness, any past medical issues, and so on. Then we will arrange some laboratory tests, which include routine exams and hormone level tests. We also need to do imaging checks, specifically CT and MRI scans. In addition, we have to go through other necessary documents like the hospitalization certificate and the anesthesia assessment form. Usually, patients are also advised to undergo visual acuity and visual field tests, as well as hormone level and vascular examinations. The purpose of all these comprehensive screens is to make sure that each admitted patient can have surgery without any problems, and we can avoid delays caused by things like menstruation or the patient taking anticoagulant drugs. After the surgery, the first thing we do is review the patient's anesthesia method, surgical approach, and their condition during the operation. Then we provide intensive care and give oxygen to the patient as prescribed by the doctor. At the same time, we closely monitor the patient's consciousness, pupils, speech, and limb movement. Once the patient wakes up from anesthesia, we will assess any changes in their visual acuity and visual fields. For patients who are restless or still unconscious, we will use protective restraints to keep them safe. In addition, we need to check the wound dressing regularly, especially the nasal dressing, to see if there is any bleeding or fluid leakage. We also need to accurately record the patient's fluid intake and output. Actually, post-operative management is the most critical step in treating thyroid region tumors. It directly affects the patient's recovery effect and long-term health. Specifically, during the post-operative period, we need to focus on several key aspects. It concludes the intracranial hemorrhage and the water electrolyte imbalance, diabetes insipidus, cerebrospinal fluid renorrhea, and the hormone replacement therapy and other aspects. Intracranial hemorrhage is the most dangerous complication after the cranial surgery. It usually happens within 24 to 48 hours after operation. What signs should we watch out for? For example, if a patient wakes up from anesthesia but then becomes increasingly drowsy, responds more slowly, or even falls into a coma again, these are warning signs. Also, blurred vision or new visual field defects can mean that might be an intracranial hemorrhage. So, as a nurse, we must closely monitor changes in the patient's consciousness, pupils, and vital signs. And we should also pay close attention to the changes in the patient's visual acuity and visual fields. Once any signs in the intracranial hemorrhage are detected, we should report to the doctor immediately. Next, let's talk about the second complication. We need to focus on the nursing care for water electrolytes. The common types of electrolyte disorders in these patients are hyponatremia and hypernatremia and alternating sodium abnormalities. So, as a nurse, first we need to monitor the patient's serial electrolyte on a regular basis as the doctor orders. We have to track the test results closely and deal with any abnormalities right away. For the patients with abnormal electrolytes, we should monitor them at least twice a day, once in the morning and once in the evening. We also need to pay extra attention to patients with critical electrolyte values. These must be addressed within 30 minutes. At the same time, you should closely observe the patient's consciousness, pupils, and vital signs. We may also need to repeat blood biochemistry tests several times a day to keep an eye on changes in their serial electrolytes. Now let's shift our focus on another key point for patients who undergo their new endoscopic transnatal approach. Treating cerebrospinal fluid rhinorrhea during the perioperative period is a top priority of our management work. So how we do to prevent the rhinorrhea? First, we usually instruct patients to maintain a proper body position. Most of the time, we keep the head of bed elevated at about 30 degrees. Then, as a nurse, we need to closely monitor the patient's nasal cavity for any wounding or bleeding at the root site. We also need to tell patients to keep their emotions stable and avoid doing things like forceful coughing, sneezing, or bleeding their nose. These actions can easily lead to the rhinorrhea. In addition, we should assess the patient's bowel movements. If the patient is constipated, we must advise them not to. We must assess the patient's infection status, avoid straining, and when defecating, and we can give them laxatives as prescribed by their doctor. One more important thing, if clear, no sticky fluid flows out of the patient's nasal cavity, we should first figure out whether it's cerebrospinal fluid rhinorrhea. Once we suspect it, we need to report it to the doctor immediately and provide appropriate treatment in a timely manner. Besides the preventing the rhinorrhea, hormone supplementation is also crucial for the patient's perioperative management. In addition, after surgery, patients may also have some discomfort like pain or sleep problem. Some patients may even have epileptic seizures or psychiatric symptoms. For these patients, we must provide them with both safety and comfort care. For patients with central hyperthermia, we need to give them physical cooling in a timely manner. And for patients with hypothalamic obesity, we should pay special attention to helping them control their weight. With the popularization of the enhanced recovery after surgery concept, the hospital stay for patients with cell-region tumors has been getting shorter and shorter. As a result, patients are in great need of health management knowledge after they leave the hospital. At the same time, the early nursing care after discharge is really important for their post-operative recovery. So what do we do to support their recovery after discharge? On their first day, After discharge, we will conduct a telephone follow-up with each patient. Besides that, we also recommend online medical service to them. What's about the intelligent platform developed by our nursing team provides patients with popular nursing work the internet also supports the patient's 24-hour intelligent question and answers. This not only means the patient's health is well, but also helps them recover better. Now let's summarize what we have shared today. We have always strived to provide high-quality perioperative care for patients with cell-region tumors, and we also make every effort to deliver excellent continuous care after their discharge. Based on their timing theory, we divided the nursing care for cell-region tumors into 5 stages: the diagnosis stage, the perioperative phase, the pre-discharge phase, the adjustment phase, and the adaptation phase. And each stage has its key focus. During the diagnostic phase, the nursing strategies aimed to facilitate a smooth hospital admission, enhance the patient's initial understanding of cell-region tumors, and reduce anxiety associated with diagnosis. In the perioperative phase, the nursing strategies include strengthening perioperative care to prevent complications, enhancing patient education to reduce fear and anxiety, providing them educational resource. The discharge preparation phase, the key nursing strategies include setting rehabilitation goals, formulating recovery plans, offering home care guidance to enhance self-management skills, and providing discharge information to connect patients with post-discharge resource. During the adjustment phase and the adaptation phase, the nursing efforts include the medical channel follow-up and the provision of continuous care service. And the nurse will provide the guidance on functional rehabilitation exercise and support them in adapting to post-operative living conditions, emotional encouragement, and assistance in reintegrating into society. Also, with the development of intelligent healthcare, we also employ the intelligent nursing models. The above is the official account for our world. Welcome other teachers and professors to follow us. This is a great opportunity for me to communicate with all the professors. As I'm still in its period, I would appreciate your valuable comments and suggestions. Thank you. That's all.
Ms. Liu? Ms. Liu, or maybe Dr. Selfie? Any question to her?
Thank you.
Can we
Dr. Kato.
invite the comment?
So I would
Sorry.
yes. Congratulations. I think it's a very thorough, detailed, and you explained and you make everyone understand the role of nursing and the patient that underwent the endoscopic pituitary surgery. And I'm impressive for the numbers operation. I saw that even your chordomas number, which is actually very rare, but I think you have 150 and then the others like 700 for pituitary. So I think you are very experienced in taking care of this kind of patient, and you show that by and I think it's a very thorough and will be very useful for the patients to have it in hand after surgery. May I ask for your experience? So before surgery, since that you have so many patients experience already, what problem usually you encounter before patients deciding to agree to go for? Is there any specific concern for the patient? And I understand that maybe some of them are very reluctant to do the surgery. So I would like to learn from you how to explain or help the patient understand what will happen during the surgery and what are the most common problems that you encounter for patient that doesn't want to surgery.
Our mic is not working, it seems.
Mm.
No, Dr. Liu's connection is unstable. That's why her mic is not working.
Lu, can you hear us?
Miss Lu, can you hear? Hello? Hello? Miss Lu? Hello?
Her connection is unstable. We cannot see her.
Till she is available, we can discuss among ourselves also.
Yeah, that would be better.
It was a good, thorough presentation from Ms. Lu. And because there are different nurses, they take care in different part of the pituitary tumor, like Selfie said, preoperative care and convincing the patient, making them ready for surgery. That is equally important, especially nowadays when we have patients which we find incidental tumors. They don't come with definite symptoms, and we think they might need surgery, and to convince them is one part. And making them prepared for the surgery, and especially while doing the transsphenoidal and telling them that they'll have to breathe through their mouth for a few days. Sometimes we put the packs in both the nostrils, and if we tell them beforehand that you might have to breathe through your mouth, then they find it so comforting. So those patients we forget to tell. If we don't tell them, they find it so difficult to breathe. So these things are important. And in our part of the world, we always are afraid after doing pituitary or cellular tumors about the postoperative electrolyte imbalance, and patients having diabetes insipidus, having to bring so many fluids for the patients, and sometimes they have to get 20-25 liters of fluid in a single day, and they are worried what's happening to my patient. So, and the part of the nurses are so important in these things. And intra-op, it's very important because intraoperatively, when we try to remove more of the tumor and go near the carotids, and sometimes we have bleeding, and at that time, if the nursing team is not ready, we might even lose the patient sometime, because if we don't get the anticoagulants in time, the flow shield or the surgery cells. So being ready is very important even during the surgery. So overall, this type of tumors require very efficient nursing and very much support from the nursing team. Any other comments from Selfie or others, please?
I want to add something that I thought that it's worth to mention. The hormonal imbalance can be easily taken care by the endocrinologist, and the hormonal assessment, it's very easy to access there. But I'm from Indonesia, and I don't think we can either the drugs or the lab in all of the island that we have here. My hospital is a national referral center, so many of our patients comes from other island. So I have to be very careful to make sure that hopefully I didn't cause permanent deficit of the hormonal imbalance, because it's very hard to taking care of. So I don't know in experience, but I'm very afraid of taking out the normal gland. So in my practice, even though sometimes there are still fixed between where sort of guidance, so that how many I can take out without any permanent deficit. So I think that's what's difference in my practice compared to.
Yeah, that's a well taken thing, because if we remove the normal tumor, then patient has to be on lifelong support for cortisol and thyroxine, and some people, they tend to forget to take cortisol and they come with crises. So these are important things to consider, definitely. Now, is Miss Lu available? I don't think she's available yet.
Okay.
Prof. Anyaku, you have something to comment?
Yes, thank you so much. Thank you. Yes, it was an interesting presentation from Nurse Peng Wei. Yeah, in patients post pituitary excision, yes, we should be cautious of visual acuity, and visual field, especially in patients who have not had visual defects. Patients who have not had visual defects post-op following some complications like hematoma, tumor bed hematoma. Patients' visual vision can start to deteriorate, sometimes without even the patient knowing. So we should ask direct questions. As nurses, we should ask direct questions about the patient's vision. And then we should take a pre-op visual assessment. This will guide us post-op to monitor the patients. For those that had visual impairment, are they improving? For those that have not had visual impairment, is there any deterioration? So visual assessment pre-op is important. For nurses, please. Visual assessment pre-op is very, very important in post-op care of these patients. Then a patient who has had nasal discharge. The question now is it CSF leak, or is it nasal, just nasal discharge, normal nasal discharge from irritation? So how do we make the difference? It's important to know the difference. So clinically, we should assess. You know, the CSF is salty. You have salty sensation in your mouth. You know, post-nasal drip. Are you having salty sensation in your mouth? If there's a salty sensation, then that patient is likely having a CSF leak. Okay. Then where the patient is, where we are not sure of what is leaking, then we should now go for a test of B2 transferrin, which is sensitive and specific for CSF. So this is important. So on that note, I will say thank you so much for this interesting presentation. Much appreciated.
Yeah, Miss Lu is available.
Miss Lu, you have anything to feedback?
Yeah, I think I want to answer the question from the professor. And she has asked me how to do their education and what can we do if the patient declines their surgery. I think and in our department we should first we will have comprehensive screens and is to make sure each patient admitted they are suitable for the surgery. And then before the surgery, we have many manners, education manners, such as the oral education and the video education and the written papers of the education. We will give the patients about the safety nursing and give them the information about the post-operative care and the symptom monitor and the complication prevention and the discharge education. Also, for the patients, I think the health care is important. Maybe they just in our department maybe not more than 10 days, so we should give them some comfort to make sure they feel warm in our department. They can feel not fear and not anxious without anxiety to go to the surgery. That's I want to share.
May I ask something, Miss Lu? How do you
Yeah.
carry out telephone follow up with the patients? I think this is one of a good method that to nurse to follow up with this type of patients, because many countries we don't have this type of services and we don't have enough nurses to do that. How do you encounter any problem when you do telephone follow up?
Yes, I think the telephone follow-up is very important, but we must have one nurse to do this thing. So sometimes it may take one afternoon to do this work, but because it's important, so we have do this day after day. When we do the telephone follow-up, we also see some patients they have their fever or their headache or their they maybe have some they maybe have we will give them some education and we will for the patients they should go to the hospital. We also give them advice to come to the hospital to see the doctor. The telephone the follow-up telephone, I think it takes some time, but it makes the patients more safer. Besides,
So how often do you do the telephone follow up?
we have the how often after when the patient discharge the next day we will give him the telephone follow up. Also we have the we use the intelligent service to do their follow-up. Their time we should, for the patient, they don't have some questions, or we will do once 1 month for the patients. We, if he have some problems, we will we will do more.
More often, you mean?
Yeah, more often. Yeah.
Yep. Thank you. Any other comments from Dr. Selfie?
Thank you. I think you see a lot of these patients already. So based on your experience, what are their concern after surgery? What kind of problem that they usually mention to you during the call or maybe in the ward? What are the problems, the main problems in your experience?
When the patients discharge, maybe after the most thing but they feel very worried. I think is the patient, the I think the most worried is the complication, and many patients when they go home, they will ask us how to how to 去就是怎么鉴别这些并发症。就是they may when they go home, they will worry about their dangerous complication, because such as their cranial, such as their water electrolytes and their cerebral spinal fluid rare and their hormone replacement therapy. They don't know how to do when they meet these questions. So when they go home, we will give him the our doctors and some information and their to help them to connect us.
Do you ask them to measure the intake and urination every day and then fluid intake? Do they measure and then report to you during the call, or how do you educate them?
When they
For the intake.
when they in the hospital, we will give them the education about the water electric light imbalance. We will educate him how to write the fluid intake and output. When they go home, we will give him a paper to help him to record their fluid intake and intake and output. When they have question, maybe they don't know if my intake is more than normal, or do I have to have their medicine? Maybe they will when we give him the telephone, he may ask us. Also, they will scan our official account to leave some message to me.
Okay, thank you. A very nice and thorough and detailed observation afterward. Congratulations. Thank you.
Thank you.
Prof. Kato, any comment, Prof. Kato?
Okay, thanks so much. So maybe I think Dr. Lu. So the congratulations, because not only your assessment but also the beautiful slides. I congratulate your great effort to present today. And also that you're very lucky because the Tenton Hospital is one of the best hospitals in China, I think.
Mm-hmm.
So you experience so many cases. I think maybe you can lead the Asian nurses, especially that region, that you can teach them and you can share your experiences, I think. Thank you very much. Congratulations.
If there's
more
no further comments or suggestions, I think, Ms. Lu, thank you very much for the very informative presentation. And we have learned a lot from you. Actually, more and more new technology, new information evolving in neurosurgery. I think nursing in neurosurgery is one of them. So pituitary post-operatively is care is very important, not only post-operative, even before operation, the preparation, the health education, psychologically preparation for patients and families, all are equally very important. Once again, thank you very much for the wonderful talk. And I think we shall close this session. We'll meet again. Thank you very much for the two speakers, the session chairs, and the commentators, and Prof. Anyaku. Thank you very much for joining us as well. Prof. Kato, thank you very much to be with us again, support us. Thank you. Till we meet again.
See you
Thank you.
again.
Bye-bye.
Bye.
Thank
Dr.
you.
Lu, maybe
Thank
you can come to Japan. It's very close. Beijing, my place is Nagoya.
Professor Wu is Mongolia.
Huh?
He's
Mongolia?
born in China, but his nation is Mongolia, Inner Mongolia.
Inner Mongolia. Okay, okay. So
Yeah,
it's very
he's
far.
Chinese. He's Chinese.
Very west part. But even
Yeah,
though.
his name is a Mongolian name, Inner Mongolia.
Oh, I see. Okay.
Okay.
But sometimes you
Inner
can come to
Mongolia.
Yes, please. Yes.
Okay.
Just
All
next
right.
to the Mongolia, I think, but located in China.
Yeah.
Very common station. Thank you so
Okay,
much.
Thank you. Bye-bye.
Thank you. Okay, so see you again.
Meet again.
Bye.
Thank you. Bye-bye.
Thank you.
Bye-bye.